My name is Suzanne Solomon. I'm a geriatrician at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Geriatrics is a specialty of internal medicine, and it focuses on the medical issues that are more common in older adults, usually over age 65. Today, I'm going to share with you some of the recent updates that we've seen in geriatric medicine. These are the topics we're going to talk about. Post-operative care. What's better after the operation, going home or going to an inpatient rehab? Then I want to talk a little bit about technology, smartwatches. Are they reliable in detecting atrial fibrillation? Next, they asked me to talk a little bit about COVID. And of course, the biggest thing for us with COVID has been, like for many of you, the coming of age of telemedicine. Then I want to talk about B12 deficiency and treatment, whether shots or pills are better. I want to talk then about brain MRIs and the white matter little diseases that we see on the MRIs or on the CAT scans and how they can affect our gait. Then while we're in the brain area, I want to talk about amyloid PET scans and whether their time has come in terms of diagnosing Alzheimer's disease. And I want to switch to another part of the body, and that is vaginal estrogen. Is it safe? It's been around for a while, but is it safe to use? Then I want to talk about something that many women use, which are pessaries, but they're not really talked about very much. So I'd like to talk about those. And then at the end, I'd like to just talk about a few myths about getting older. Okay, so the first thing is about total knee replacement. Total knee replacements are becoming more and more popular, especially with baby boomers wearing out their knees and wanting to go running marathons for the next 20 or 30 years. It's estimated that by 2030, there will be 3.5 million total knee replacements done per year. They are very effective, but they're also very expensive, and Medicare is trying very hard to figure out how to save money. After the knee replacement surgery, people can either go to a rehab facility, or they can go home and they can get rehabilitation at home. They can do it by having a physical therapist come to the house or having telemedicine do physical therapy. The difference in cost is staggering, between 5 and 25 times more expensive to go to a rehab than to go home. But the question is one better than the other? So there have been several studies, this is the most recent one, that looked at people who went home after total knee replacement versus ones who went to a rehab after total knee replacement. And they checked them at 10 weeks and they checked them again at 52 weeks. And what they found, that recovery was the same, whether they went home and got rehab there or whether they went to inpatient rehab. So I think the important thing about this study is that you don't have to automatically assume that people need to go to inpatient rehab after total knee replacement. Of course, there are some people who are very frail, who don't have home supports, who may need to go to rehab, but actually the vast majority can go home. The next thing I want to talk about smartwatches and whether they can help detect atrial fibrillation. So we know that atrial fibrillation is a very dangerous arrhythmia. It's very common and it's often not picked up. It can increase the risk of a stroke by 5 times or more, but unfortunately, many people show up with a stroke as the first knowledge that they have atrial fibrillation. Whether or not you get an EKG in the office, or whether you get one of those Zio patches or a Holter monitor, because atrial fibrillation is often paroxysmal, it can easily be missed. So Stanford University and Apple Watch teamed up together to determine whether wearing an Apple Watch, which you wear for 12, 14 hours a day, can actually be helpful in picking up atrial fibrillation. What they did was they sent a message to people who did not have atrial fibrillation saying that they could sign up for an app that they would be involved in a study. If atrial fibrillation were picked up by the watch, a message was sent to Apple, and they sent to the person a little monitor, almost like a Zio patch that they would attach to themselves, wear for 7 days to see whether they actually had atrial fibrillation. They were then supposed to send back the little patch to see what what rhythm strips were found. 400,000 people signed up for this, which was a big surprise to everybody. They monitored for 4 months, and at the end of 4 months, 2,000 people got notifications that they had an irregular pulse. It was only 0.5%, and it wasn't that much, but out of those 2,000 people, 30% of them, more than a third, had atrial fibrillation lasting more than an hour. So for those people, it was really important that that atrial fibrillation was picked up. Interestingly, out of 2,000 people, only 450 of them returned the patches. So in a follow-up survey, they asked these people, why didn't you return the patch? And more than 50% of them said as soon as they got the notification, they made an appointment with their doctor. All right, the next thing I want to talk about is COVID. I think we've all been watching the daily updates on COVID, which seems to have affected the older population slightly more. But one thing that it has done is it has vastly increased for all of us the telemedicine visits, both telephone and televideo visits. They've done multiple studies. This is just one in psychiatry showing that the people felt that the telemedicine visit was just as effective as an inpatient visit. However, for an older population, there are tremendous pros and cons. For instance, for somebody who has to come into a doctor's office, they have to make plans way in advance. They have to get a ride. They have to take a family member or a friend, ask them if they can basically take the day off to take them to their doctor's visits, or they have to make an appointment with the ride. And so for them, these telephone visits are amazing, and they love them. Unfortunately, what we have found in the geriatric population is that most of the older people in their 80s and 90s, don't have smartphones. So doing a televideo visit by smartphone or computer has really been a bit of a challenge. But the phone conversations have been extremely successful. There has been some resistance by clinicians, and we are, of course, still rolling out the best way to do this. And of course, you can't examine a patient, listen to their heart or their lungs, but if you get especially a video visit, you can really tell a lot about what's going on. So hopefully especially for the older population, this is something that's going to continue. Ever since March 6th, Medicare has been paying for these visits, and we all hope that they will continue to do that. Okay, next thing I want to talk about is B12 administration. So B12 has been around for a long time. B12 deficiency is an extremely common thing to happen to people as they get older for many reasons. One of the biggest reasons is that the stomach stops producing gastric intrinsic factor, and so B12 is not absorbed as readily. In addition, a lot of the medications that people take, such as antacid medications like PPIs or H2 blockers, metformin, the vegetarian or vegan diets that people are on often lead to low B12 levels, which are often not checked. Unfortunately, when people have low B12, they can get all kinds of symptoms such as neuropathy, anemia, memory loss, weakness, fatigue. The estimate is that about 20% of older people, have some sort of a B12 deficiency. It doesn't take very much to keep an adequate B12 in our diet. The minimal daily requirement is about 2 to 2.5 micrograms. And in the past, it was very common for people to go to their doctor's office, get a monthly B12 shot, and they would just feel all pepped up with all kinds of energy. The problem is that now we have an alternative. We have B12 pills. The pills come in 500 or 1,000 micrograms, which, as you can see, is several hundred times the minimum daily requirement, with the idea that if you overload all of the negative things that are preventing B12 from being absorbed, you can get adequate B12. The shots are expensive. The pills are 3 cents a piece. So Canada, like the United States, is trying very hard to decrease their medical costs. And this study, which done in Canada, looked at 146,000 people. And what they found was that 25% of them had normal B12 levels, and yet they were getting B12 injections. This was before they even got their first injection. Almost 40% of them, of people who were getting B12 injections, had no B12 level even documented. The estimated cost of what they called inappropriate B12 injection prescribing was $45 million. And only under 2% of people who were given intramuscular B12 injections really needed them. So why do people still get B12 injections? Well, it turns out that not everybody knows that a high dose B12 pill can actually bring up the B12 levels just as well. And in addition, there are some patients who still like coming into the office to get their B12 injections. They like the visit, they feel that it is better. I want to talk now about what we have all seen, and that is reports on brain CAT scans or brain MRIs of those little white things that the radiologists frequently comment about. They usually put it as an incidental finding. We also know that gait and balance problems affect many people as they get older. In fact, by age 80, almost 50% of people will complain about something wrong with their balance or their gait, and very frequently we just have no idea why that is. Going back to the MRI and CAT scan findings, I just want to make you aware that these have all kinds of different names depending on which radiologist is reading them. They're called small vessel ischemic disease, white matter disease, periventricular white matter changes, ischemic changes, leukoariosis, all kinds of things, but they don't really give a lot of follow-up as to what this could mean, except could be microvascular disease. So this particular study looked at the relationship between those little white things that we see on the head CTs and gait and balance. And it turns out that the more heavily represented these white matter changes are on the CAT scans or the MRIs, the worse the gait is. So we don't know exactly why that is, but we do know there's a correlation. It is very possible that some of these white matter changes in the brain are similar to the cardiovascular changes we see in the heart, and that perhaps we should be thinking about these in terms of treatment, treating them just as we do coronary artery disease, possibly with aspirin, possibly with statins. I have pictures here just to show you this brain with just a little bit of the white matter density, so it's mild vessel disease. This one is moderate vessel disease. And here you have really severe, lots of white changes on this. And these are the people with the worst gait. So it often does help explain to people why their gait is bad. And you can help them then with physical therapy, with getting canes or walkers, etc. While we're in the brain area, I want to talk a little bit about PET scans. PET scans of the brain looking for dementia, but particularly Alzheimer's disease, have been in the research department for years, and that's pretty much still where they are. However, we are starting to move in slowly to starting to use these for diagnosis purposes. We know that an amyloid PET scan has a great deal of sensitivity and specificity, even though for right now it is just used in research. The main reason is that Medicare and many of the insurance companies won't pay for a PET scan because they feel that until we have some sort of a disease-modifying treatment for Alzheimer's disease, what's the point of spending millions of dollars getting PET scans? So the question is, would a PET scan change how we manage patients with Alzheimer's disease? There is a study which started in 2013, which you should know about, because it is now in phase 2, but it's called the IDEAS study, which stands for the Image Dementia Evidence for Amyloid Scanning. And what they did was to see if amyloid PET scanning really does help when it comes to changing management for dementia patients. The way this was done was they looked at 16,000 people who had some sort of memory loss, and they asked them to go to some sort of a memory clinic where they would be evaluated by so-called experts, specialists. And these could be neurologists or geriatricians or internists who would do testing on them in the way we've always done testing on trying to rule out Alzheimer's disease. They would come up with a diagnosis, and then the patients would get a PET scan. And the PET scan and the clinician's diagnosis were compared to see how closely they correlated. So what they found were that there was actually quite a difference in the two. 11,000 people completed the study. Amyloid PET scans were positive in 55% of people with mild cognitive impairment and 70% with dementia, mostly Alzheimer's disease. But what was interesting that was when they compared these to the diagnosticians, they found that the diagnosis was changed from Alzheimer's disease to non-Alzheimer's disease in 25% of the time, and from non-Alzheimer's to Alzheimer's disease in 10% of the time. This led to huge changes in clinical management. And 85% of the time, drugs were changed. Either they started on the Alzheimer's disease drugs that we have presently, or they were taken off of them. So one might ask, as many people do ask, well, what if I did have Alzheimer's disease? Who would want to know? Would you want to know? So the Harvard School of Public Health actually did a study to find out whether people would want to know if they have Alzheimer's disease, since there really is not too much we can do about it at this time. 80% of Americans said they would want to know if the reason they were having confusion or memory loss was related to Alzheimer's disease. Even among older people over age 60, 95% of them said that they would want to know. And this is important because just about half of the people who are walking around with dementia do not have a diagnosis. Many of them were told that it's normal aging. Sometimes the family members say, oh, we don't want to know because we don't want to hurt their feelings. But Alzheimer's disease is a disease like every other disease, and people really should know because there are many things, just like with any other disease, that this could affect. People would want to know who would want to make advance directives. They would want to make financial decisions, tell people what they would want in the future. Okay, I'd like to move now to a different part of the body, and that is I would like to talk about vaginal estrogen. Vaginal atrophy is extremely common in women once they pass menopause. It comes with many symptoms, including vaginal dryness, pain and bleeding during sex, itching, recurrent urinary tract infections are much more common after menopause. It happens almost universally, up to 45%, but in truth, it's probably much more, have these symptoms, but almost nobody seeks help for it. It's underreported, it's undertreated. As a matter of fact, the North American Menopause Society told women who came to them having pain on sex because of vaginal dryness that if they only had more sex, it would get better. So you can imagine that people didn't bring this up a second time. We do know that systemic hormone replacement therapy can help this situation, but we don't use systemic hormone replacement therapy for long-term and for treatment just of vaginal atrophy because of risks of DVTs, pulmonary embolism, heart disease, endometrial, and breast cancer. Vaginal estrogen has been around for a long time, but for years, people were afraid to prescribe it because nobody knew if vaginal estrogen had the same side effects as systemic hormone replacement therapy. So that's what this study was meant to look at. Here you have 3 different forms of vaginal estrogen. This is a ring that has estrogen in the middle of it. It's called the E-string or S-string. You put it into the vagina and you can leave it in for 3 months. So it's very easy, and every day it leaks out just a little more estrogen. And either your doctor or nurse or the patient themselves can exchange it every 3 months. Then you have vaginal cream, which has a tube, sort of like a toothpaste tube, and you put it in a plunger and you use this in the vagina 1 or 2 times a week. This is the same idea. It's a plastic inserter with a little pill at the end of it, and you put it into the vagina and pop the pill in, again, once or twice a week. The big problem with all of these is when you pick them up from the pharmacy and you open up the box, the first thing that you see inside is a full booklet on the dangers of these. They boil down to this: warning, endometrial cancer, cardiovascular disorders, breast cancer, and probable dementia if you use this. And then it says the risk should be assumed to be similar for other dosage forms of estrogen. So of course people are afraid to use it. But in this particular study, which was a very large study, they found that actually estrogen users had no more of any of these things: stroke, breast cancer, colorectal or endometrial cancer, pulmonary embolism, or DVTs, were not different between vaginal estrogen users and non-users. And in fact, for some reason that we don't understand, heart disease, fractures, and all-cause mortality were lower in non-users. So I think we should all feel reassured that vaginal estrogen is safe. I want to talk now about pessaries. Pessaries have been used for centuries. They find these mummified bodies that have pessaries in them. They are used to treat pelvic organ prolapse. So this is a big problem. When an organ prolapses and comes out of the vagina, it can block the urethra so that people get overflow incontinence. Their bladder never empties. They have more urinary tract infections. They are constantly having to go to the bathroom. But if you have a pessary which pushes up the organ, and I'm going to show you a picture of which organs it can push up, then that takes care of the problem without surgery. In the United States, a doctor, usually a gynecologist, measures, puts in a pessary, and then every 3 months they go back to the doctor to have the doctor take out the pessary, rinse it off, do a vaginal exam to be sure there are no ulcers or scratches or any kind of problems in the vagina, and then pops the pessary back in. In the United Kingdom, they do the same thing, but they do it every 6 months instead of every 3 months. So this study was done to see if there's a difference between 3 months and 6 months. These are the various pessaries. These are just actually a few of many, many different kinds of pessaries that are put into the vagina to hold up whatever is falling down. Just to show you, this is normal anatomy. This is the bladder with the urethra, the uterus, and the uterus and the rectum. And any of these can prolapse, blocking the urethra. So in this study, they compared people 1-to-1. And what they found was that in the 3-month arm, there were problems with over 7% of the people, but at the ones who came in only every 6 months had much fewer problems. So it turns out that getting your pessary changed every 6 months is actually safer than getting it changed every 3 months. They asked the women, would you prefer every 3 months or every 6 months? And needless to say, 92% of them said every 6 months. Okay, very quickly, I want to end up on myths about aging. We all think about older people as being alone, miserable, lonely, sitting by the phone waiting for somebody to call them. And it turns out that this is just not true. Studies that they have done show that myth number 1, depression is more prevalent in old age. It turns out that actually emotional well-being improves well into the 70s. Cognitive decline is inevitable. Not true. Approximately 25% of people will develop dementia, but 75% of them are out there learning iPads, learning the computer, going to classes, learning Zoom. Myth 3, older workers are less productive. Actually, people love having older workers because it turns out that they are kind of settled and not moving from job to job. Next myth, loneliness is more likely. People actually make more friendships as they get older, and people certainly get more creative as they get older. They asked people at different ages whether they felt their age younger or older. So it turns out when you're under 30, you definitely feel your age. But after 30, it turns out that most people feel younger than their age. And this goes whether you're in the 50s to 60s, 70, or 80s plus. more than half of people feel younger than their stated age. So just to show you how important it is, this is a 97-year-old woman who does this every single day. Her mind is quick as can be. She does the stock market every day. She is in the gym every day and does her exercises. And this is our last slide of her. This happens to be my mother. And with that, I will say, stay healthy.